Welcome to The Explainer. Today, we're diving deep into a topic that is absolutely essential for anyone in anesthesia or neuro-intensive care, the critical care management of aneurysmal subarachnoid hemorrhage, or as you know it, aSAH.
And hey, for those of you gearing up for your final anesthesia exams, you're going to want to pay close attention. This is a super high-yield review. We're going to break it all down systematically, just like you see here, starting with the initial presentation, then the big threats inside the brain, moving on to the body-wide complications, and wrapping it all up with modern management.
So, let's start at the very beginning. A patient rolls into the ER. What are we actually looking for? And how do we start to figure out just how bad this neurological catastrophe really is?
Now, we're not talking about just any headache here. The classic description is a thunderclap. It's this sudden explosive event, an ictus. It's caused by that aneurysm rupture and the sudden bleed into the subarachnoid space. This can cause a massive, if temporary, spike in intracranial pressure, which is why some patients collapse right at the onset.
You might see a number like 8 per 100,000 and think, well, that's not super common. But don't let that fool you. The mortality rate is incredibly high, and the potential for severe, lifelong disability makes knowing how to manage this an absolute must for any critical care clinician.
All right, so how do we quantify the damage? Well, we use this kind of two-pronged approach. First, we use clinical scales, like the WFNS or Hunt-Hess, to look at the patient's actual neurological state. That helps us predict mortality. At the same time, we're looking at the CT scan with a radiological scale, the modified Fisher scale, which is really good at helping us predict the risk of one specific complication down the line, vasospasm.
And that brings us right to the core of the problem, the life-threatening complications that start brewing inside the brain right after the bleed. Honestly, in the ICU, this is where the real battle is won or lost.
You know, the clock is ticking from the moment of rupture, and the threats actually change over time. For the first 72 hours, our biggest nightmare is a rebleed. It happens in up to 23% of patients, and it's devastating. It carries a 60% mortality rate. But once we get past that window, a new danger starts to emerge, delayed cerebral ischemia, or DCI, which can pop up anytime between day 3 and day 21.
And this definition right here, you've got to lock this one in. DCI is not something you see on a scan. It is, by definition, a clinical diagnosis. It's what happens when a patient suddenly develops a new problem, like a weak arm, or their consciousness level drops, and we can't blame it on anything else.
Okay, this leads us to a really critical distinction. This is a classic exam question, so listen up. DCI and vasospasm are not the same thing. You can't use them interchangeably. As you can see, vasospasm is just a radiological finding. We see narrowed arteries on a scan. Plenty of patients get vasospasm and are totally fine. DCI, on the other hand, is the clinical event of the patient getting worse. Vasospasm can cause DCI, for sure, but there are other complex causes too, like tiny blood clots and inflammation.
So what do we have in our toolkit to manage all this? Well, to stop a rebleed, we get super aggressive with blood pressure control. We want that systolic pressure under 160 until the aneurysm is secured. For hydrocephalus, which hits up to 30% of patients, we need to divert that excess spinal fluid with a drain. Now for DCI, the one drug that's proven to improve outcomes is oral nimodipine given like clockwork for 21 days. And seizures? We treat them if they happen, but we don't routinely give meds to prevent them.
And this is a brilliant point, because aSAH is so much more than just a brain injury. That initial hit to the brain triggers this massive body-wide inflammatory and adrenaline-like response, and that creates this whole cascade of problems everywhere else. In fact, get this, up to 60% of patients will develop at least one major systemic issue. And these aren't just minor footnotes. These complications can actually cause secondary brain injury and make the patient's overall outcome way worse if we don't get on top of them fast.
I mean, the impact is truly all over the place. The cardiovascular system takes a major hit, the lungs can get in trouble, and we see huge disturbances in the blood and endocrine systems. And on top of it all, fever and infection are always lurking.
So for example, that huge surge of catecholamines, think of it like an adrenaline dump, that happens during the bleed can literally stun the heart. It can cause everything from weird ECG changes to a full-blown stress cardiomyopathy, what we call takotsubo. And that same sympathetic storm, it can make the capillaries in the lungs leaky, leading to neurogenic pulmonary edema.
Problems with the blood are also incredibly common. More than half of these patients will become anemic.
Now, why is that such a big deal? Well, it's an independent risk factor for a poor outcome. And that's probably because it starves the already injured brain of the oxygen it's desperately crying out for. So, based on the latest evidence, a pretty reasonable strategy is to transfuse to keep that hemoglobin level above 90.
So, with all these moving parts, how do modern critical care teams even begin to manage this? Well, it really all boils down to two things: constant, advanced monitoring and really targeted interventions that are driven by the patient's specific physiology.
Blood pressure management is the perfect example of this. It's a real balancing act. Before that aneurysm is secured, our one and only goal is control. Keep that systolic pressure under 160. But the moment that aneurysm is fixed, the goalposts move completely. We're happy with a much wider range. And then, if the patient starts showing signs of DCI, we do something that feels totally backwards. We actually induce hypertension, pushing the pressure up to try and force blood through those narrowed brain vessels.
It's a similar story with low sodium or hyponatremia, which happens in over half of these patients. You can't just throw a bag of saline at it. The first step always is to figure out the patient's volume status. Are they losing salt and water, which we call cerebral salt wasting? Or are they holding on to too much water, like in aSAH? The treatments are basically the opposite of each other, so getting that diagnosis right is absolutely critical.
And to guide all these decisions, the modern neuro-ICU is packed with some amazing monitoring tools. We've got pupillometry, which gives us hard data on pupil reflexes. Transcranial Dopplers are used all the time at the bedside to screen for that vasospasm. And there's really cool emerging evidence for continuous EEG to catch silent seizures and maybe even predict DCI before we can even see it in the patient.
Even something as basic as mechanical ventilation has to be adapted. We call it brain protective ventilation. And unlike your standard lung protective strategies where you might let the CO2 drift up a bit, here the #1 priority is super tight control of carbon dioxide and oxygen levels. We do that to keep the blood flow in the brain stable and prevent any spikes in intracranial pressure.
So let's just boil this all down. What are the key takeaways? Well, first, grading the severity right at the start is crucial. Second, and I'll say it again, vasospasm and DCI are two different things. And finally, managing aSAH is really a battle on two fronts. You have to use all that advanced monitoring to focus on the brain, while at the same time aggressively managing all the systemic problems to prevent that devastating secondary brain injury.
And this all leaves us with a really interesting question for the future. As all this monitoring tech gets even more sophisticated, and we get a better real-time picture of an individual patient's brain physiology, are we finally heading towards an era of truly personalized therapies that could dramatically improve outcomes for these patients? All the detailed information we've gone through today comes from a fantastic review article from 2021 by Carden and Zumpruli, which was published in BJA Education. Seriously, for anyone studying for exams or who just wants to dive deeper, it is an absolutely essential read.